So my name is Cunningham. I'm a pancreatic and hepatobiliary surgeon. And I'm also just finishing my master's in religion at Harvard Extension School, where my thesis is focusing on religious literacy among healthcare providers. I've been thinking about this question a lot lately as I've been writing my thesis and asking myself, what is it really about healthcare that just seems special vis-a-vis religious literacy and the spiritual care of patients? Because spirituality, according to most mainstream, widely accepted definitions, is an intrinsic part of being a human, Those of us who don't self-identify as religious per se are still spiritual. For some people, spirituality is the hike in the woods or the visit to the art show. For other people, it's something that happens during their religious ceremony. But what really strikes me, I think, about the work in healthcare is that there's two main things that separate it, I think, from work and living in a general population. One is a power differential that exists in healthcare, and another is a set of social constraints that just doesn't really exist outside of healthcare. So when I ask myself, what's special about healthcare vis-a-vis religion and spirituality, I think it's really those two things, a power differential and these more rigid social constraints that don't exist really outside of healthcare. So for example, the first one, when you encounter a colleague or a neighbor or a friend in the grocery store, these are people who may well be your peers. There's not necessarily a power differential. One person isn't relying on the other person for health care, for example. And that's an important thing to keep in mind, that power differential exists in healthcare. So that's one thing that I think really sets this work that I do in healthcare related to religion apart from the also very important work regarding religion and spirituality just in our daily lives. The second thing are the social constraints. Because the world is very diverse, but in the general population, as people are going about their business, they tend to self-select, I think, with people who are in the same in-group. People who look, dress, think, pray, eat like they do, generally. I mean, that's, I think, something that's pretty typical for humans. So regarding the second point, the social constraints, when people are going about their daily activities in the general population, I think they generally self-select according to their preferences. We humans, I think, generally like to eat, think, pray, dress. They like to be with people who eat, think, dress, pray like we do. So anyway, so those two aspects, I think, is what really sets apart this work that I do in healthcare vis-a-vis religion and spirituality from the, I think, equally important work in the general community. So I think this work in healthcare, it's really interfaith work. So if interfaith work is work that we do with individuals and communities who orient differently around religion, bringing them towards greater cooperation and understanding, then in healthcare, the individuals are the patient and the provider, and their communities are for the patient, all of their family, their friends, their support groups, and for the provider, it's all of the various people who surround them. And it's a lot of different people. It's their colleagues, the staff of the hospital or the office. It's all the trainees who are observing and noticing what's going on. And so those are the communities. And the work at hand is the health care of the patient. And the important thing is to recognize that that work requires increased understanding and cooperation of all of those different members of those groups. Yeah, I think one story that sticks in my mind about what it's like to work with patients in a healthcare setting while paying attention to religion, religious literacy, and spirituality is a guy I saw in the office who, like all my other patients, answered a few questions that I have them answer in the waiting room, and then I go over with them face to face in the office. And they're It's basically a screen for spiritual distress. And I first ask patients, do you sort of self-identify as religious, spiritual, both, or neither? And then I ask them a few questions about essentially a screen for spiritual distress. I ask them, are you at peace? I ask them if they're having any struggles currently that revolve around religion and spirituality. And I ask them if they're struggling with peace, with meaning and joy in their life. I ask them if they're struggling with meaning and joy in their life. And so those are some screening questions that I do to screen for spiritual distress. And so this one patient answered the first question, neither, which a lot of people do. And so we didn't spend a lot of time in that first consultation talking about it. And so he had his operation, which went fine, and then he came back in the office for a post-operative follow-up visit. And it was one of those situations in healthcare where the visit is almost over, hand is on the door, and he's like, wait, you remember that question you asked me before about religion and spirituality? Well, it was really both. And so then he wanted to talk about everything. And so what this story really illustrates for me is that you have to meet patients where they are. And so that story resonates with me as a reminder that people are at different places, and especially when they're dealing with something in healthcare, which is often a moment of crisis for patients. The patients I deal with, for example, are often just receiving a new diagnosis of cancer, or are facing what may be a life-threatening operation, which really any operation could be. It's a crisis moment in a patient's life. So these are times when patients come from different directions and process it differently. And so that story really reminds me that you have to just meet people where they are. Yeah, I think the most important thing I've probably learned, and certainly I'm continuing to learn, and hopefully will continue to learn as time goes on, is just how important it is to meet patients where they are. And sometimes that means giving them space if they're not ready to engage with a discussion about religion or spirituality, and sometimes it means sitting down and just taking those extra minutes to explore those issues with them. And sometimes it means helping other people in their healthcare, their other providers, trainees who are learning how to take care of patients, to recognize the importance of the interfaith work, of meeting people where they are. And even though the provider and the patient-provider team may orient differently around religion and spirituality, still being able to move towards greater cooperation and understanding. Yeah, so it's an essential question, from what perspective did you come? Because like Donna Haraway, one of the historians of science, once said, we can't do what is called the God trick, which is to be able to see everything from nowhere, because we're all somewhere. So where we are coming from, what our own perspective is, what our own faith tradition is very relevant for our interactions with other people. And in fact, some of my favorite courses are in this Master's in Religion. For example, one of a survey of world religions had us start by identifying where are we in the whole milieu of religion and spirituality. I think it's an essential question. So for me, it's been a lot of different phases. When I was growing up, actually, I really was as ignorant of religion as one could possibly be, given that I was, growing up in a society which, like all human societies, was deeply steeped in religion. The particular society I grew up in was steeped in Christianity in southern Denver. But my mother, who had fallen away from the Catholic Church several decades before, decided to come back to the Catholic Church right around the time that I would have been bused to a dangerous part of Denver where there's a lot of gang violence. So instead of doing that, she put me in a small private Catholic school. And then she and I both she re-entered and I entered Catholicism in the 7th grade. And so for the next 10 years or so, I was a practicing Catholic, living what I have always thought of as a pretty typical devotional Catholic Christian life. And then for that went on for maybe 10, 20 years. And then for the next 10 or 20 years, I became, ironically, much more engaged with religion, but less religious myself. And so I don't know what I would call myself now. There are many terms I think that have some accuracy. Maybe a secular humanist, maybe a religious naturalist, maybe a Christian agnostic. All of those I think may be appropriate. But what's really important to me is love. And I think that the work that we do in our daily lives, interacting with other people, and especially in healthcare, when we're taking care of people, has to be imbued with love. Because work that's done from a place of love and gratitude is better and more effective work.